So how is COPD diagnosed?
So COPD is diagnosed as a clinical diagnosis and should be considered in any patient who has shortness of breath, chronic cough, chronic sputum production, history of exposure to risk factors, and any family history of COPD. And up here, I drew a table that you can see. So shortness of breath, progressive, and it worsens over time. Characteristically worse with exercise and is very persistent, so the shortness of breath won't go away. Chronic cough may be intermittent and may be unproductive, so we may not be able to cough anything up. Chronic sputum production, any pattern of chronic sputum production may indicate COPD as well. History of exposure to risk factors, tobacco smoke including popular local productions, smoke from home cooking and heating fuels, occupational dust and chemicals, and then again any family history of COPD. So that's a little chart I put up here. Do you remember Mrs. Tubbs' post-bronchodilator FEV1?
Oh, that you showed me earlier? Yeah, no. I don't know how you can remember so much of this. Information is pretty overwhelming and it's just an overload. I don't know how you can do it.
Louise, I definitely understand. I studied long and hard when I was at Ball State's respiratory care program. Pulmonary function testing was not my favorite topic. Once I got hired, I actually began obtaining and assessing spirometry values on a regular basis, and it really began to stick in my brain. You'll see what I mean one day.
Well, thanks for being so positive and understanding. My father had a spirometry test way back in the day. Can you explain why it's so important or such an important assessment tool for any COPD patient?
Yeah. Spirometry is required to make a clinical diagnosis of COPD and should be available to all healthcare professionals who work with COPD patients. In spirometry, it's a simple test that measures the amount of air a person can breathe out and the amount of air that's taken in to do so.
So how is exhaled gas measured then?
It's measured by using a spirometer, and this is a device that is used to measure how effectively and how quickly the lungs can be emptied.
Does it show the exhaled volume?
Yeah, it shows. It's called a spirogram, and it's called it is a volume time curve. And there's a couple values. Forced vital capacity is the first one, and it's the maximum volume of air that can be exhaled during a forced maneuver. And FEV1 stands for forced expire volume in 1 second. And in the first second of maximal expiration after a maximal inspiration, this is a measure of how quickly the lungs can be emptied. And the FEV1 divided by the FEC is what we look at to see if it's restrictive or obstructive disease. This really helps with us diagnosing that. And is expressed as a proportion of the FEC and gives a clinically useful index of airflow limitation.
That's so confusing. I still don't understand how it relates to the goal that we were talking about earlier.
Well, the ratio of FEV1 and FEC is between 0.70 and 0.08 in normal adults. Less than 0.70 will indicate airflow limitation and thus of COPD. So Mrs. Tubbs' most recent post-bronchodilator FEV1 over FEC is 65%. By using evidence-based goals categories, we can classify the severity of Mrs. Tubbs' airflow limitation. And I'll put up here, I'll erase this and I'll put it up here, the chart. So you have 4 classes of gold 1, gold 2, and gold 4. So you have different severities. It goes mild, moderate, severe, and very severe. So this is mild, this is moderate, gold 3 is severe, gold 4 is very severe. And Mrs. Tubbs, she was 65, so we'll remember that. So this is an FEV1 greater than 80% of predicted. This is an FEV1 50% to 80%. This is an FEV1 of 30% to 50%. And this one's FEV1 of less than 30% predicted. So hers was 65, so hers is going to be between the 50 and 80. So she'll be goal 2, which is moderate. So these are her values right here. Okay.
So the gold classification is essentially a simple way to categorize how severe a COPD patient's airflow is being limited based upon the post-bronchodilator FEV1 value. And gold 1 indicates the most ability to blow out air, and gold 4 is the worst classification, and it means that the patient has the least ability to blow out the air. Is that right?
Yes, that is correct.
So does every adult have the same predicted FEV1 as hers?
No, FEV1 is influenced by the age, sex, height, and ethnicity, and is best considered as percentage of the predicted normal value. There is a vast literature on normal values. Those appropriate for local population should be used. So, spirometry is needed to make a clinical diagnosis of COPD. Together with the presence of symptoms, spirometry helps gauge COPD severity and can be a guide to specific treatment steps. A normal value for spirometry effectively excludes the diagnosis of clinically relevant COPD. The lower the percentage predicted FEV1, the worse the subsequent prognosis. So I'm going to go up here and erase this. Yeah, we can. So I'm going to draw a spirogram up here. This, we'll put the normal one over here. So this is normal, and this is someone with mild to moderate COPD. Okay, and we'll do, so this is liters on the side. So we'll do 1, 2, 3, 4, 5. And this is seconds. Six seconds we'll do. And then, so a normal person, this is what theirs will look like. With this being, oh, let me go back a little. So, right here, switch it up. So this is their FEV1 right here at 4 liters. This is their forced vital capacity at 5 liters. So if you take the FVC or the FEV1 divided by the forced vital capacity, it equals right down here, 0.8. And remember that was a normal value from 0.7 to 0.8 for a healthy adult. We'll do the same thing. Okay. So this is what a COPD's spirogram may look like. And their FEV1 says 1.8 liters right here. And their forced vital capacity say 3.2 liters. And if you take the FEV1 divided by the FVC, you get 0.56, which is lower than this, and it tells us that it's an obstructive disease, which helps us diagnose COPD. So you can see the airflow right here compared to a normal person right there.
Big difference.
Yeah. So the FEV1 declines over time and is usually faster in COPD than in the healthy subject. Spirometry can be used to monitor disease progression, but be reliable, the intervals between measurements must be at least 12 months.
So how do you perform the spirometry test?
I'm glad you asked. Mrs. Tubbs is eating breakfast, so I have time to show you how to do a real demonstration.
Will it hurt?
No, it won't hurt. I will talk you through each step, and then we can look at your results.